if we're going to be doing the sort of focus on carers, some of the large scale work, I suppose, are highlightable at the moment. So one is from what's possible from an ICB, the new integrated care systems, the new health and care bill, how that's going to affect change with palliative and end-of-life care being noted. And now there's going to be a formalisation and prioritisation, which means there will be a budget aligned to palliative and end-of-life care. So there's certainly a lever and an opportunity to, there's a knowledge exchange, probably seen, if not later I can get the link from the chat, where there's an opportunity for us to progress some of this conversation and be able to potentially suggest positive changes through that process. And there's also the Bereavement Commission coming up. There's an opportunity from one of the commissioners to be noted on the UK Bereavement Commission, but that's doing and has the potential to do a huge amount of work sort of across the UK from a change perspective. There are things across the workforce, but there's not a huge amount that we can probably do about that to save the universe. So I agree, the community focus is definitely essential. There's some really interesting work that's been done in Southwest London, but it's now been elevated to an end-of-life care NHSE quality improvement pilot. There is some sort of awarding system, and that's about community engagement and real dialogue and how we do that. So we've mapped the bereavement pathway. So that's Lucy Selman's work and Emily Harrop, who've seen it from the patient's perspective and the challenges, and mapped the other part of it with Caroline Pearce's evidence base, which is the challenges that frontline professionals are tasked with. So we've sort of married that and then created a sort of focus group and surveys and questionnaires and things that we've posed to particularly underserved communities. So and worked with Health Watch and voluntary organisations to make sure we had the right groups of people. Phenomenal things that we've actually heard that we would not have thought if we'd just done more of the same from a commissioning perspective, and it really sort of unlocked the unmet need, and it's sort of powerful consequences both for communities and sort of leaders that have been quite engaged with that. There's also another project that I'm involved actually with a different which I forgot to mention, which is difficult conversation. So I'm clinical lead and director for a little social enterprise that organically grew from NHS, but then as it grew, the NHS said, we can no longer house you. Would you like to go and create a social enterprise or not? So I said, yes, why not, with a couple of us. So we're working in Surrey. It's the beginning. So we submitted a proposal to develop it's a neighbourhood and street carer champions. And so there's a format of, there's a test site available. We've got a sort of structure that they're really pleased about. So it will be using the quality improvement across a population approach. So it's quality improvement outcomes for general practice and health and care partners. Then there are quality outcomes for sort of carers. So there's a bit of in-depth work to do with carers to sort of sense their local needs. And there's sort of training up carer champions on each street corner. So they will be looking to map their community and their streets and see what the sort of carer needs are, but actually you could broaden that, to then be able to interconnect with their own streets. So they become their own little sort of ambassadors of carers and a resource of knowledge. And there's an interchange between, the sort of, instead of it being a social prescriber housed within health, it's really, emphasizing the importance of streets and neighborhoods. So there's a potential framework that they're looking to scale, but they want to sort of test that out in quite a small ward size, but it's alignable to a PCN. Then what else? There are the Daffodil Standards. So the Daffodil Standards are a lever as well. They're the RCGP Marie Curie quality improvement program, so they're free. There are 8 standards. Carers are one of those, and bereavement care after death is another one of those. We've done a large amount of work across the bereavement, but we've done less work from the carer perspective. There's some phenomenal, I don't know if you know Gun Grand and Gail Ewing, who work in Manchester and Cambridge. They're carer end-of-life care research genii, and they're doing a lot of qualitative information, big NIHR research proposal, and that's pulled out a lot of the themes. It's sort of heartbreaking, actually. I was near to tears as I was thinking of other people that I've known and lost. And it's really sort of powerful research base to be able to then progress lots of other work or to use in communities. And there's also, I suppose, the lever of the general practice and commissioning perspective, so guidance that we could use. We developed some similar, you were saying, a sort of pack for carers. I suppose the learning I had recently, I thought it was going to be brilliant. I'd invited all of my South West London Carer Hub experts and local authority leads and other carers, and I said, what would you like? What shall we organise? This fantastic training for you with hospices and wonderful people that will come, and manual handling and how to do injections, and it could be wonderful. We had about 10K, and they looked at me flatly, and I knew I was flatlining at this stage. What would you like to do? So we had a whole scoping exercise, and I wonder, sort of sense checking what it is that, and how we might be able to sense check what people actually want and need, and what that gap is that
let's open that question out.
There are lots of things what people like.
Catherine, am I right in thinking that Carers on Street Corners is your Chertsey work? Is that right?
No, it's under the Difficult Conversations.
Okay,
so
cool.
But I'm also happen to be a GP in Chertsey, so it's easy to work with the general practice and the rest of people.
Because certainly the discussions in COIN around end-of-life care in the last few months have dipped in and out of the individual personal drama against a local community stuff, including community development and carers and networks of carers and whatever. So I would certainly be interested for you to add a bit more insight into how one achieves healthy deaths at scale, and collaboration from schools and faith groups and various people locally, and carers can indeed become glues for community development. But here, what about other people, please? Just very quickly, Linda.
Yeah, thanks very much. Just trying to unmute myself. Am I unmuted?
Yes.
Hooray. Thank you very much, Catherine. My thoughts are, I really like what you're saying, and I'm really interested in what you're saying. But the trouble is, I think the reason that it may be the reason that you're meeting this slightly sort of, I don't know, kind of confused response is probably because they've been around the circuit a few times, and they've heard these things in different formats from different people before, and things don't change. And that's the problem. So I think there's a certain sadness and cynicism, maybe it's more sadness and cynicism amongst people in the sector. I speak from higher education, I've heard it before as well, and we've tried to do things to change the situation, even in the learning environment, to make a difference. I think the issue for me is always about how do we get this kind of brought into the mainstream, so that it's no longer just a project, but it's actually accepted that this is working, this is the way it works, and this is how it could work and should work, and how can we make it work? And I think that's the issue. I'm sorry, I'm not saying you're not doing great stuff. I really do see that. And I think everybody has to move forward, but there is a long history of this sort of initiative going on and not progressing, disappearing into the background, and somebody picks up something else again. There is the continuity of development. That's the concern I have.
I don't see other hands up wanting to steer the conversation in any particular way. Laura.
Well, I wanted to kind of think about it from the scoping exercise that you were talking about with carers. I started as a hospice volunteer 30 years ago, and then became a nurse in hospice and oncology, and then became a nurse practitioner and then family practice. And so here I am now 30 years later, sitting with my mom, remembering the same lesson, that the person at the end of life looks different from day to day, hour to hour, week to week. And that's always, that roller coaster is so hard for family members to both roll with and then remember. Like last week, we did everything we could to figure out how to get a favorite food soft. And then suddenly they didn't want that food at all anymore, and everything shifted. So as I go through that with my mom, trying to find somebody who could be at the house for just an hour to do her toes, but not any other time of day, it just reminds me that more than any other kind of care I've been a part of, it shifts so quickly and people forget what they need because it doesn't feel as structured. It's more about being present. And that's even harder to put into policy. So more of a thought. But I also want to draw attention to Sanjay's comment that the King's Fund in London are doing some work on end-of-life care. I know with integrated care and a lot of my work in primary care integration, King's Fund has always done some very interesting work. My guess is that you're probably aware of that, but I just wanted to draw attention to his comment because I know he's not always able to get his microphone to work.
Isabel. Unmute.
Used to Zoom, so I'm struggling to do things in Zoom. I just wondered, I was listening to what you said, Catherine, and I think there is this tension around, we kind of often don't know that people are at the end of life until they die on us. So certainly the package, I guess, so the package that we've been, and I'm the primary lead in my practice, so we call it integrated care complex, and it's a holistic support, but with anticipatory care. And we've just recently introduced what we're calling wider determinants, which is basically about social exclusion, digital exclusion and social isolation. And actually off the back of COVID, that's gone down really, really well. So it's been quite interesting. So we're saying to people, would you like us to support you to reconnect, or and so people, and so we've, obviously we're mainly using our social prescribers to do that, but we are exploring. We've got, during COVID, our borough created something called community champions, which I thought resonated with some of the stuff you were talking about, Catherine. Yeah. So we're trying to explore how we kind of repurpose them away from COVID and into just life. But I was just thinking in terms of a lot of what you were describing, and it comes back to that tension between specialist palliative care, which is very, last days of life, as opposed to primary care. And I think personally, I wonder whether we should, my experience of working with this group is that actually often what you're doing is working with a successive number of losses of independence, of mental capacity, financial issues, maybe having to leave your home. And so I think sometimes death is actually welcome. Death isn't it's all this loss that people go through in those terminal phases. I mean, not everyone does, but working with this group, very often that's what we're struggling with. And particularly when you have family networks where, say, you have a pair of really frail older people, and as long as they're both all right, they just about manage, and then one goes, the whole thing falls over. So yeah, I can kind of, so I mean, obviously and I'm fortunate that we've got two GPs in my practice who are the kind of lead GPs in this area, and the other GP, worked in a hospice for 2 years, and so he tends to do the last days. But this wider thing, and the other thing that is so frustrating, is that we get little or no support about prognosis. So we actually are asked to talk about prognosis, and I don't know. And I know that sometimes other people don't know, but for example, heart failure, there are prognostic models, but can we get our heart failure consultants to actually have honest conversations with patients? No. Can we get them to give us decent, even on the information that they do know about? No. So we are left as GPs kind of going, and it isn't, it's a struggle, I guess. So there's lots of things I would like to have more of.
Okay. We'll come back to that. Before we go back to Catherine, I just wanted to check Becky, Paquita, Christine, and anyone else for that matter. One thing that COIN's been talking a lot about has been, how do you normalize these things? As long as every death is such a big drama that it's everything has to be done new, you really aren't going to be able to achieve the things we're talking about. But if we say, look, this is a normal part of life that everyone has to face and we're all going to do it, and so in this particular neck of the woods, we're going to be prepared for it. And here's how we'll be prepared for it. You've got a different kind of story going on. And I'd be quite interested in whether your work in Chertsey and difficult conversations can get at that, say that we believe that this can be managed better by simply thinking in advance. And we've already had several really great speakers at COIN talking about this. So Christine, Paquita, Becky, any of you? Just speak.
I think I'm working now, is that right?
Yeah, you are. You are.
Hi. I've just put on the chat. I've had a bit of a funny week really this week. I've been assessed. I work for continuing healthcare. I'm actually an occupational therapist by trade, and I'm working alongside another occupational therapist to look at other ways other perspectives of care and looking at other models from an occupational perspective. But my day-to-day work has been a funny week because I assessed a gentleman who has got quite progressed dementia and Parkinson's and is being cared for at home. And I've been working with his family to look at support planning. And the comments from the family were quite interesting because this gentleman's in the 3rd floor of the house and cannot access outside at all, really, because he can't get downstairs. And I'd asked his wife about whether that's something he wanted to incorporate in his support plan, getting him outside, looking at those human needs. But it's become so reductionist that she's been so focused on meeting those clinical needs that she said, I haven't even thought about those needs because I've been so focused on this kind of reductionist kind of plane that she's been living with.
Yeah.
And that's really has really sat with me all week. I found it quite troubling that that someone can find themselves in that situation when they're facing somebody who's got a sort of an end of life progressive condition.
Let's make sure we dip into that. Any other thing you want to say, Becky?
No, that's where I'm at this week.
Very acutely where my wife was dying, about how that particular night I hadn't actually arranged anything to cover my kids if I had to take her into hospital in the middle of the night for whatever reason. And the very I hadn't thought of it was extraordinary to me. But then actually, why didn't anyone help me think about it either? Because it's not part of the system.
No, exactly. And I think that's it, that we become so clinically focused.
Yeah.
That we can forget, and that we can forget about those human needs that just that we should also be thinking about, and not let the clinical needs overshadow some of those things. Yeah.
Can I just
another hand? Who was that? Was that?
It's me. I just wanted to follow on for what Becky just said. I'm again just referring to the King's Fund. Their view is that end-of-life care is not primarily a health and social care event. It is first and foremost an event that happens within the context of a family and a community. And I think that fits in very much with what you've just said.
Okay, well, wouldn't it be nice at the end of this, in a couple of months' time, if COIN could come out with a way of thinking through, just anticipating these kind of things? Okay, who is that, sorry?
Well, it's Laura. I was just going to draw attention to what Catherine has posted in the chat as well, is the link to the approved work in palliative and end-of-life care and the 8 items of the bill, which really is in line with some of the conversations we've had over the previous months, that end of life isn't always predictable, but there is a sense of loss that happens, and that paying attention to both the carers and the clinicians in those stages is more than just a system prescription, as much as caring for the carers and caring for the clinicians who care for the carers, and the systems to share all that information. I see that in the 8 items, Catherine. So maybe you could talk a little more about how that all connects with this holistic set of conversations we're talking about.
Great. I hope you got enough to work with there, Catherine. I just want to add in that there are other people who aren't in here today who are very much part of this discussion and want to be part of it. For example, David Peters, who edits the Journal of Holistic Health, and Andrew Papanikitas, who edits the British Journal of General Practice part of it, well-being part, I think, which are actively asking COIN to write about these things for their journals. So, Catherine, over to you.
I was thinking of 2 main things. I mean, one, I was remembering, I think I remember coming to see you, Steve, in good old days of when I was an embryo of starting, and you showed me these Vireo charts of basically about the combinations of staff, good experience and sort of a good experience from patients. If you looked back, there was well-planned care. And I wondered if there was some, it stuck with me a lot, sort of how we sort of triangulate different aspects of information to see what's actually worked well. So I suppose, is there something around that, particularly from a caregiving perspective? And the other bit that it's reminding me of is, I don't know if anyone has mapped, you know, very specifically recently, working with South West London again, it was particularly trying to look at rapid burials, but in order to do that and what was going wrong, I physically had to work with different partners to map every tiny little detail of what has to happen in order for the next stage to happen, and for you basically to get a good, hopefully a good experience at the end of it. And then once mapping every little bit from an evidence base, and also just sort of frontline experience with different people, because it went all the way up through to after death, we looked at, well, what are the challenges for each different facet of that? And then what are the interventions? Are they easy wins? Are they things that we're going to have blue sky thinking? Is it legislative that we're going to have to change? And I think there's almost an element, because otherwise it can get very big, and we can potentially focus on something that we as a group might think this is a fantastic idea. But I think unless one stands back and looks at the enormity of the challenge and what does one need to do across each single little bit of, I don't want to call it a pathway, but in my mind it's a sort of flow thing, in order to get sort of good results at potentially different times. And then what do we need to do, and what is the task that you want to achieve? And then there is just, the reason I put it in the chat is there is this window of opportunity of, if you want to submit to the knowledge zone, kind of now is a really good time for that, around palliative and end-of-life care. There's also the APPG on bereavement that's coming up. So Laura Finley is doing a big piece of work with a number of national partners, and I'm sure there might be something that you could contribute. They're normally quite helpful when we're sort of, particularly when she's looking to lobby for certain things. So carer support may well be one of those, if you've got an informed sort of argument or case for her. So supplying her with information, often I found very, very helpful over the last couple of years. I've been looking at the key 8 items for the bill. I mean, is there something around, you're all going to have a large network between you of different types of people and with different experiences internationally by the looks of it. So is there something around, we discussed a bit of this at the think tank, but it was more broadly around end-of-life care. But if it's specifically focused on carers, if you've got the King's Fund in the background of having that theme, which I think is incredibly helpful, is there something about trying to compose and collate within your network ideas of what fabulous can look like? Because whilst it's easy to often map the challenges, and that's equally important, is there something of giving, you know, sort of politicians the gift of, this is what it could look like. These are different models of when it does go right, and these are some of the things that, if you do some of these particular components, critical success factors, whatever you want to call them, you can actually really improve the care, the life, the living of both carers and people that are being cared for. And I'm just thinking of, I mean, I suppose I always think there are critical windows of opportunity, and if this is the work you're doing, I wouldn't let that pass, because it was not going to come round again that quickly. I don't think. So it's, I suppose, highlighting the levers and opportunities, but I do think there's something quite powerful about painting a picture for people that are empowered to maybe be able to pick up, whether it's, you know, even powerful visuals, not just written pictures, but sort of powerful visuals of pictures and communities and things where it works well. And if you're able to collate those, to be able to say, this is a, you know, this is a positive experience, this is what we want to see, because otherwise often it's a lot of complaints of what we don't want to see. And I think
we'll pick up on that straight away. Nikita, Christine.
Sorry, I can't see hands at the moment.
Okay.
Well, I mean, I'm new to this discussion, so, you know, I don't want to preempt any, but I just would like to clarify what you mean by carers, because, you know, looking at I just was checking the figures. I mean, people dying at home is less than a quarter. It's 21.7% in the UK. The majority are dying in hospital, nearly 50%, long-term care institutions, 18. So what do you mean by carer? Do you mean just the people at home in the community, or do you mean carers in care homes and also carers in hospitals? So, I mean, we've got to get real about this. I mean, one of the reasons that I think death isn't normalized and part of, you know, normal community is because it's been warehoused. And we are, as a society, in denial. And actually, if you think of the beginning of life, and I know Steve Iliff, is, you know, was supported, as I did, home births. It's a bit the same. You know, it's been very medicalized, and it's been, you know. So I just would like to clarify that, because unless we get more people dying at home, properly supported, you know, that it's going to be hard to get change. I'm sorry, I'm just thinking.
Oh, so I can come back on that.
So who would like to pick up on that?
I'm happy.
Catherine, go on.
So, well, I think it's important clarification. So really, it's about, you're right, around sort of 40–45% of people dying in the community. Some of those are care homes, some of those are home deaths, as you rightly said. I suppose there's been a 10% increase nationally of people dying, and it's been sustained from PHE data, Public Health England data. And it's just continuing, and there's been a 50% reduction of inpatient deaths in hospices. So, you know, some of that is from people not choosing to go to hospices, and definitely people that are avoiding. But from that, there's sort of been a learning, I suppose, of wanting and seeing and valuing the importance of being surrounded by people that, you know, your loved ones, particularly in the pandemic, to avoid being stranded and not being able to see people dying. However, the important part is, so at least a third of people never go into hospital before they die. And the majority of time, even though you might have the 50% might be your last admission, so last days of life is within death, is dying in the hospital, the rest of the time you're living.
Yeah.
And, you know, it's care, from my perspective, I was mainly talking about informal caregivers, you're right, but that could be further clarified by sort of trained carers or paid carers in the community or in hospital. So, but I think informal caregivers are definitely underrepresented and have specific needs that need supporting.
I mean, just to pick up on that, I mean, one of the problems is that carers are very underpaid and undervalued. They're not professionalized in the way they could be. And then on the other side of the coin is, I mean, the Lancet was giving, for example, the Kerala model, which has been very successful in India. And it's not like this key items. It's because that's, again, quite specialized, isn't it? Palliative care having to be available. Well, there are not many palliative care specialists around. Why not train local people to be, you know, to be the advisors and helpers and supporters? Wouldn't that work better? And more, anyway, sorry, I'm just, as I said.
Let's keep that one on the table. They've done this in other countries, haven't they? You know,
yes.
Donde no hay dottore, and you know, community matrons, women in local areas, like in Soweto, the nurse practitioners do a whole set of voluntary work there to develop the community around this kind of area. It just isn't thought of.
You know, I was trained as a volunteer 30 years ago with weeks and weeks of training to be present and sit with a patient in home, and to help both emotionally and physically move patients and help the families to adjust. And it doesn't take a lot of clinical care. It was before I had any clinical training. It set me on a great path as a clinician. But what I saw then 30 years ago here in the US was that we had patients on hospice for an average of 6 to 12 months. They tended to receive a diagnosis of hospice, receive care at home, and then actually live longer with a better quality of end of life time. By the time I finished being a volunteer and became a nurse, the time on hospice services was 3 days, and the average patient was dying on intake to hospice. They stayed longer with oncological care. They stayed longer with clinical diagnosis. They stayed longer in hospital. And you know, that I think was still a system problem of not letting patients go to a holistic experience of end-of-life care, which can last for a very long time, and not thinking of it as a death experience, but actually this quality of time that is not just about clinical care. So I think as clinicians, we let people down by not helping them to see all these other options.
Yeah.
I think they're out there. It's not that they don't exist in England or anywhere else. It's that we have to be working together as both clinicians and community services to realize how they all fit around a patient and the family.
Other points on this, Catherine?
Well, I've just popped some stuff in the chat. I mean, I think it all knits together. There's some fantastic work by Loros, which is they've interviewed and they're telling stories from different sort of people's backgrounds and whether it's sort of religion based or where they're from. And I think it's really, and there's also some fantastic work with King's as well. I think it's North Central or maybe Northeast London around sort of cultural awareness and culture, but actually they've kind of mapped people's frontline professionals' understanding. So using the right language, understanding what their motivations are. You know, some people will not, if it's actually the religious leaders that they're going to listen to and will value the care from, and it's pointless, then there's a lot of distrust from other communities. So it's the complexity of that, of actually how you get to really serve all people across our population becomes sort of much more detailed, but certainly being able to reflect different options, I think, is important. And I think I think there's a fundamental issue about the commissioning structure of what we're looking to support. There's so much opportunity. You know, when we did our focus groups, it's a couple of £100 per focus group to get people sort of engaged, to hear their stories, and yet we will fund year on year, increase on increase, different services, big services, and we'll give them more funding with very little evidence of improved outcomes. And I think if we're not tackling that fundamental issue and the structure to aim for improvements, we can, you know, from grassroots, you can achieve a lot potentially within some communities, but for me, there has to be a bit of push and pull. And at some point there will have to be, you know, enabling, tackling from the sort of lobbying perspective. So I think a sort of multi-faceted approach is very important. But I suppose the query back is, what is it that you're as a group wanting to bite off and chew, and that will make the most valuable difference for you as individuals, but also where you think you can really make a difference. I mean, I'm happy to support in any way, and would love the support from like building, agree the sort of small pilot and testing, but I completely agree, if we don't have something across all edges, from top down to bottom up, then it does, you know, we'll miss certain opportunities.
Yes. Was that?
Yeah. Well, it's really interesting in hearing Paquita talk about it, and then just Catherine there. That I wonder whether, is it going to get more difficult? You know, because we've got integration happening. We've got the new Health and Care Act, and that's changing the way in which essentially commissioning is done. And you know, potentially we've got a little bit more stronger trust, public body, you know, involvement really on the board of the Integrated Care Board. Less interestingly, you know, potentially GPs from what it was before. And I just wonder if, you know, hearing Paquita, hearing Catherine, that is it going to be quite more difficult to get these concepts in, these more local concepts and the thoughts and things that you've been seeing into a commissioning structure, which, you know, obviously there's going to be a lot of advantage between sort of bringing together more the providers and the commissioners together, but actually it feels like it could be more heavy from a NHS trust kind of perspective as they get sort of more people on the board of the Integrated Care Board. So how do we get that across could be a really interesting issue.
Let's just tease this out. Isabel, let's have you in here.
Just to say, I was on my CCG, the Tower Hamlets CCG for the 7 years, and I'm now Primary Care Network Clinical Director, and I also convene the group for the networks across Tower Hamlets. I am not optimistic about commissioning from an ICP, which is essentially what used to be the region. And what I think I mean, and that's one of the reasons I've dropped out of the kind of higher level stuff and have retreated back to Tower Hamlets. And what I do think is that whilst the primary care network DES is a wonderfully flawed concept, they keep pushing it back, but there is this thing around personalization. And actually, I think one of the interesting things, that whether it's COIN or RCGP or whoever, I think we should make a land grab for multimorbidity, end of life, functional deterioration as the group that we should really be gunning for personalization, because in essence, it's taking, I think it goes back to what we were saying earlier on about that demedicalization. I really, really liked what Laura was saying, because actually, you know, it's about making the time that people have got as high quality as possible. But also the other thing I was reflecting on, so sorry, that was my comment about the legal changes. I'm a bit nervous about them. The other thing that I was reflecting on when you guys were talking, I've done lots of work around digital as well, and I was sitting there with a presentation, I've forgotten the name of the product, about supported decision making about whether you're going to have your knee replaced. And actually it was fantastic, because they had like people talking about the experience, and it was, well, so the idea was that, you know, you and your family sit down and watch this. Essentially it's like a YouTube clip. And I just think that because death has been medicalized and tidied away, and let's not talk about the war type stuff, I actually think people have no understanding. And if I think it's the things that have made us be able to sustain a death at home are often around the daughter ringing up and saying, she's breathing funny. You know, and actually if there's not somebody around to say, yeah, that's what happens, this is fine, you know, you're doing really well, let's just stay with it, I'll pop around and say, you know, stick my head, or, you know, one of the nurses is supporting. So people just don't know. And you have, you know, frail 92-year-olds whose family is saying, no, we want to resuscitate, we want you to do everything. And you're just thinking, how do we show that story from the human side, not from the clinical side, about what this choice means? People telling that story. I mean, I'm thinking about some of the, I can't remember, Kieran Sweeney stuff. I mean, you know, I just think we need to hear the voices of the people actually going through it, both the families, the nurses, and of course the people. But you know, I don't have any of that. You know, so I'm having a conversation saying, oh well, I don't think resuscitation is a good idea, and it's, you know, I don't have anything sensible to share with people that's written by people for people. And I don't think the cultural sensitivity stuff, sadly, is in North East London, unless it's a bit that I haven't caught up with. But I'd be very interested, Catherine, to connect that. But anyway, I would be saying, let's try and leverage something into the primary care network space. I think personalisation has been kicked into the grass for the end of this financial year.
I'm very keen to come back to Paquita before we lose this thread, because this is potentially very powerful. Essentially, just primary care isn't necessarily going to be able to understand a lot of this because it isn't inside primary care practitioners' experience. But then they're suddenly expected to know all of this. Who is going to be on the end of the phone to help the wife, the husband, the daughter, the son talk about he's breathing funny? You know, who's going to do that?
Maybe Catherine's social enterprise.
Well, maybe. I mean, I've got an interesting situation that my next door neighbor on one side, had an end of life, and my other side had an end of life, and somebody who was coming to help us went back to Ukraine, as it happens, to look after her family when her mother died. And every one of them were talking about non-medical things. Medicine didn't figure in any one of them. One of the mother and the father died next door. She's got special needs, you know. Who's going to mow the lawn?
You know, yeah, I think back to my time teaching nurses in West London, and you know, nurses aren't actually taught general practice at all in the UK. And very much a lot of what I found in my research was that we weren't really giving them regular updates around things like vaccination and other things that happen in primary care, because you're trained to be in hospital as a nurse. So all the nurses that are a part of the GP practices also aren't getting that material. And they're often the first ones who pick up the phone or have that first conversation before the GP. And so some of the package of training might be tailored towards nurses and practice nurses in particular, especially because they're or community nurses, that a package around end of life, grief, loss, and elderly care isn't something that's usually a part of the curriculum. So there could be a focus audience there that could be combined with the GP's package of care. And that's part of what I looked at around primary care, but there was no end of life in the material.
Christine.
Connect truly with Laura, because when I initially started palliative care, just as a graduate nurse, the only thing that I've learned or a skill check in my nursing skill book, logbook, is only how to do last office, and there's nothing more about end of life. And sort of like reflecting a lot on the experience about how to breaking bad news to patients and their family members, and experience with how medical practitioners handle, in the hospital handle people with end of life is very traumatizing for myself when I was a student. And when I became a palliative care nurse, a lot of expectation is that an old nurse will come and visit us and not a young one. So a lot of people were asking, like, are you qualified or are you a student? So they start, like, asking my qualification, and they were shocked, like, who are you? Like, why are you come and talk about, about life and end of life? And that's pretty confusing for me when I initially started, but I've learned a lot throughout my experience from my patient. And there's this one patient that asked me a very legit questions. Looking at the 8 bills that Catherine has posted, he asked me, doctors can prescribe, when we come to the clinic, doctors can prescribe when you have flu, they can prescribe medications. When you have headache, they can prescribe Panadol for you. But can you medical people prescribe empathy, prescribe loneliness, prescribe happiness? And these are the things that really stuns me. And coming back to what healthcare is all about, is about caring, is about people, is about why we are here, taking care of them. I guess just coming back to the simple basic thing. Yeah.
Okay, going to come to Steve and then Isabel, but just before you speak, we've got about half an hour left, and it strikes me that we're still so exploring ideas that probably, unless other people disagree, we should stay in this one group for the rest of that time and not go into a breakout room. Very keen to hear a bit more from Paquita. Tony Birch hasn't spoken yet, and then Catherine, of course, as well as anyone else who's got something else to say. Steve.
I'm hearing lots of solutions, but I've lost track of what the primary problem is. Can somebody define that for me?
I think we need to go back to the pathway, because I think it's a complex, there are so many, it will be multifaceted. And that's why I don't think there's going to be multiple challenges to get to different bits of a good experience. And therefore there will be different interventions done by different people that are required. So it might, the question is, what would you like to focus on? Because there are probably multiple bits, would be my.
Okay.
query back.
Anyone else want to have a stab at that question? Paquita, Tony, Linda, Laura? So whilst you're thinking about that, Steve, what the problem for me was there were ordinary things I wasn't prepared for, you know? I wasn't prepared for the people who were going to lose their heads and start creating all kind of madness because they didn't know what to do. And I somehow thought that I wasn't prepared. How does one engage your kids, your teenage kids, in a death when, you know, I may have helped lots of people as a GP over the years, but I've never actually had it in my home. And then my mum gets unwell and I don't know what to say to her. So not prepared for the everyday. But I want to hear other people.
But before you do, can I just clarify on that? So for you, the primary problem was that you were unfamiliar with the territory, but nevertheless forced to be in it.
Yes, that will do. That will do. And also, I thought I knew. But then, you know, hey.
You are a doctor.
Yeah,
that's the thing, isn't it? In a way, Paul, I think you've summed it up really well. Nobody is prepared for this. That's the issue, isn't it? That's what we're describing. And I suppose, you know, you thought you were because you're a professional, but it still comes home when it's your own family that's affected. So in a way, what you really, I think what we'd really like is for people along the pathway, whichever pathway it is, because there are many, would actually be able to help you along the way in an appropriate way and be listening to you and recognizing it isn't a set piece. So that for me would be, you know, a really good outcome, because we're all struggling at the end of that life. Nobody sort of expects it. Nobody's, as somebody said, you know, you're living and then suddenly you're not. Along the way you suddenly deteriorate. So I think it would be really great if more health professionals and social care and other people within the community, because you've talked about the person on the street corner, all could kind of get the picture of working with the individual and their families as very important aspects, to understand that this is not a set piece, but you have to work with what's happening at the time, but be aware of it and be ready for it. And maybe there are some lessons we can pass around, which would be great.
I come back on that, but I want to hear from Isabel.
I was really resonating with sympathetic with what Christine offered, and just to say that the thing that saves my bacon is that we work as a team, and so we do have very good links with the community health services team. District nurses are always a bit difficult because we struggle to keep them, but have very good care navigators. I've got a very good mental health liaison person, and quite apart from the human stuff that of course I don't know about people's lives, but the things that came up were things like I didn't know how to plan a funeral. I didn't know when somebody's died, so what do you do next? I didn't know how to do mental capacity assessments. We started doing sort of functional assessments, and actually just starting to talk to people about, well, where does your food come from? You know, so actually, and that was often done, I didn't necessarily do that, but that we collectively tried to have a perspective on all of that. And obviously that doesn't always work if somebody deteriorates too quickly for those assessments to happen. But so I just wanted to kind of not lose sight of the integrated bit, because I think if we go back to that, somebody did that analogy with getting pregnant and giving birth. You know, then you've got loads of people who want to tell you about it. I mean, I remember when I got pregnant, it suddenly felt like it was like joining the Masons or something. Suddenly people started telling you about all sorts of stuff that nobody had ever talked about before. Unfortunately, it doesn't happen like that in end of life. It's like that it's almost like unclean. We can't talk about it.
Ooh,
and so
that's a good one, yes.
Yeah, so for me, that comes back.
Everyone knows you daren't talk about, yeah.
The bit that really I think we haven't is the community. I mean, and I think there are some, I mean, I use the Compassion in Dying website, and I love it because it has been written by people who've gone through the journey, and it's not medical. And I just think there's something about, you know, yeah, we've got our set of skills, but you know, it's a teamwork, and the absolutely core central team member is the person.
Yeah.
A few more voices on this very important theme, please.
Yeah, can I just say, based on my personal experience, that the thing, apart from of course having that team around me to support me, was just simply being told by people, you're doing a good job.
Oh God,
Because
that's so important.
I was just so afraid that I wasn't doing the right thing or I wasn't doing enough. And actually the person who meant most to me was my father himself, telling me, you're doing a great job, you're providing me with great care. But with the attitude and behavior of others, both before and after his death, was absolutely critical for me to enable me to get through what I was going through at that time.
Yeah. I see nods all over the place, Sanjay. Very much identify with that. A couple more voices, please. We've only got 25 minutes.
Yeah, it's teamwork, isn't it? And the patient is in the center as the most important person there, and as a really important team player. And it includes the professionals, it includes the family carers, and anyone else who happens to be around. I'm really interested in this discussion and about being able to talk about death and dying as we do. I mean, that lovely comparison with childbirth, and it all fits into, they're all parts that fit into a whole as far as I can see. So I haven't said very much, but I'm really enjoying the discussion.
Thank you. Bekita?
Yeah, I mean, what I'm hearing is education. Is that people need to know, you know, they need to know about frailty, you know, that gradual deterioration, and they need to understand what happens in those last days and what to expect. Because I think, you know, if people are, I mean, the other thing is there needs to be better communication between primary and secondary care. And I just was telling Paul the other day how so often as a GP, when I was doing the out of hours work, I would go to a home with a patient who'd been discharged. We can't do any more for him or her, and they're dying. But the relatives have not been told at all. And it's a great relief to them when you say, actually, your aunt, your mom is dying, and which she can go back to hospital, but they're not going to, it's not going to extend her life very much, and she'll be surrounded by machines, and you'll be alienated, and you won't be there to comfort her. And then we did have then a hospice at home with the district nurses who would come and be supporting those last days. But it was extraordinary how often this seemed to happen. I mean, almost. So there has to, maybe, you know, even the junior doctors who discharge these patients from the hospital, the A&E or wherever it is, or the other thing that can happen is that relatives panic. Suddenly the patient's gasping, they call 999 and off they go, and they have CPR and all their ribs are broken, and they have a traumatic death in a hospital. So we need to educate somehow. This has got to be root and branch education, even starting from school, I think, so people know, you know, what happens in those last, you know, senility, you know, that downward path. And obviously sometimes it is sudden, but we're talking a lot, aren't we, about that sort of gradual decline leading to death. And the other thing I just want to say is we should be looking more at volunteers and community. I mean, this Kerala model, for example, they had neighborhood networks, and people, it says here, transformed how people lived. People with incurable diseases had people coming to visit them at home, supporting the families with care, mobilizing community resources, keep the children in school, food, helping bereaved spouses find work, etc., etc. And there was a medical nursing team there on site, but a lot came from the community. And compassionate communities is a similar model, which I haven't heard talked about, but, you know, so, you know, rather than getting too managerial, I think we should be looking at resources and assets in community and education. And, really, we're talking about birth, and there's so much, again, all those lovely books on birth and, and pregnancy. Well, there should be more books,
You're talking about inner city.
About that other great life transition. Yeah.
Talking about inner city Leeds or Birmingham or Manchester, though, Peter, yeah, quite difficult to get that community spirit in some of those areas. And I think maybe we need some more money in the area and that being directed. It's interesting that things like personal health budgets don't seem to get thought about for this kind of area, interestingly, but I wonder whether, that could help that personalization issue that you mentioned.
Anyone else want to pick up on this? Christine, Becky?
I was listening. It's a really interesting point that somebody made about being told they were doing a good job, and I remember having to giving my dad a lot of reassurance, because whilst he was dying, he spent a lot of the time worrying about us, and so having to reassure him that things were in hand, and that finances were in hand, and all the things that he was worrying about. He wasn't really worried about, what was going on with his body and what was happening with him. He was worrying about all of us. So it's a big part of the picture of the person who's dying, I think.
And just knowing that, talking about it, may be all you need, isn't it funny?
Yeah.
I'm looking for hands, and my screen isn't very easy to see, and I may be missing. Is that Isabel? Is that you?
Isabel.
Sorry, just to say, yes. So my mother was just obsessed about which bits of her crockery and stuff we were all going to inherit. None of us wanted it, by the way, but it was, everything had labels on it, and that's what she went on about all the time. Having said that, I've also seen families where that hasn't been managed, and after death, the family completely breaks apart because of the arguments about inheritances. And so again, this is the stuff that actually matters to people. We don't address that, but actually this can destroy a family.
Yeah, very strange. And it's like a diversion from anything that actually matters, that people get into a war over trivial nonsense, but you have to address the trivial nonsense because it's what they're using as a proxy for other things. Incredible.
Well, and I think that comes back to a few months ago, the conversations we had with Lynn Jenkins and others around advanced directives, that the real meat of the conversation in estate planning and advanced directives is actually about the stuff and what is most meaningful in that stuff and whose ring gets to who. That it actually wading into those difficult conversations early on is the stuff of teasing out what a family is, what a family means, and how that works. And I've luckily had 2 years of these conversations with my mother because of vision problems, not because she's ill and sick, but because she can't see anymore. And it's precipitated really good conversations. And doesn't that actually happen with aging for most of us, that you're robbed of your vision or your ability to work or your ability to hear earlier? And those could be early prompts to family conversations around estate planning, which isn't really about money, but seems like it is at first. The other thing I wanted to mention was also, not to belittle the topic at all, but 2 of the medical shows, medical dramas that I like to watch, all of them, to see how the conversations are going, just addressed this issue in really nice form here in the US. And I used to watch Holby City so I could learn about the UK healthcare system. Not saying that it's realistic, but isn't that what the people we're caring for are watching? And isn't that an opportunity to teach? And how do we influence the storytelling that's happening in social media or in media at large? And couldn't we, in fact, help influence some of that storytelling with some of these conversations? I actually tagged them to share and sit down with my mom to watch The Resident and This Is Us, because they're talking about end of life and they're dramatizing how families get into each other's stuff. And I'd much rather do that with somebody else's family than experience it firsthand with mine. So as often as I can find those online, it gives a good conversation starter. in non-clinical ways.
And use whatever people are prepared to talk about. Just talk and get at the deeper things. Come on, Christine, let's hear a bit of your Tasmanian insights there.
I guess coming here and because I left my full-time job as a community palliative care. So coming here thinking, oh, I can do some volunteering. I mean, but I feel like as a palliative care volunteer, there's a lot of restriction due to rules and regulation. And that's sort of like having to say that compassionate community things, it kind of like when you put volunteers in palliative care and the need of palliative care patients kept on changing, it is very hard to merge that two together. I mean, just from my personal experience here. And I guess, yeah, there's a lot of rules and laws sort of like limit the works or to just fulfill the needs of the patients in different form. Yeah, I guess, yeah.
Conversation's still got a long way to go. We've only got just a little bit more than 10 minutes to go. Next month, Suleika Ali, palliative care lead for the community services locally in North and West London, is speaking about the reform of end-of-life care that they are planning. So please hope that all of you will be here to just support her and applaud. They're planning something, but because community services and primary care services in North and West London do not connect. They don't speak the same language. They're missing an awful lot of things, the matter, and they're about to take this in both hands. And she's going to be here to talk about it next month. And I do hope that you can be here too. But we've still got 10-15 minutes to put some more meat on some of this bone. Paquita, I'm very keen to hear a bit more of you. Tony, Isabel, Laura. Who was that? It sounded worth hearing a bit more about, but
well, you know, I just wanted to come back maybe to Catherine. You know, you listed all these amazing initiatives that are going on, and the critical window of opportunity. So, you know, to come back to all of this great experience in the room and the hopes and dreams of what could be better, what could each of us be doing right now with those critical windows of opportunity, despite the frustration that the system doesn't always fix things the way it could and should, and the policies aren't really focused the way they should be. You know, I agree with you. It seems like a time that there's a critical window. What now, by whom, and how can we shift this given our experiences?
So I think that I definitely think there's something around what you're looking to drive to do the knowledge exchange. So to submit something, I definitely try and, you know, I can try and get it to the APPG on bereavement. So we've potentially got an in there, or I can present it, you know, in different fora. And, you know, either any one of you would be able to, but I'm happy to make the links with Alora because she loves the lobbying perspective and is extraordinarily good at it. It's because of Alora that we've managed to get the health and care bill changed. So, I mean, I think that's an important, she's, you know, an incredible force of nature, really. I mean, I suppose the other thing that strikes me, what you're sort of describing, there's the what matters most conversation. So we've done quite a bit of work around asking patients, people, what matters most to you and who matters most to you, and trying to change the language from, you know, from early years, or not just at the end of life. So by the time we actually get to end of life, whether it's been about contraception, getting married, getting divorced, whatever that might be, end of life is already on the list. And if we do that regularly once a year, it's sort of, you start to firm up what that foundation is. But there's something about what you're saying that sounds almost like, and I'm just thinking of what the USP bit is and that hasn't been done, is about how to help streets and neighborhoods, so other people, understand what they could do to help. So what they might want to think about. So often we focus on either telling the patient or telling the caregiver, and they're a bit shattered and don't, the brain is fried. But what would be helpful is trying to give people a nudge in the community to say, just check in. Could you get any do the washing? Could you give some food? Someone's coming back from hospital. Their partner may need just like a hot meal or so, whatever it is, but like little nudges. Can you paint a picture of what that would look like? You mentioned the handbook, Paul. So I'm just thinking, is it for carers? And I posted earlier on, there's something that Laura wrote, it triggered a brain cell, that in the middle of COVID, about what to expect when someone's dying, and that's very much from the patient, layperson perspective, and was written with that in mind. But there are so many opportunities. I think it's just being really clear about which one you want to bite off. But as I said, the two is knowledge exchange and enabling the lobbying structure of what good and fabulous examples there are that may otherwise go unsung and therefore be missed. And you're all describing lots of, fabulousness, but I think that voice doesn't often come through. And it's whether, you've talked about education. There are so many cutting points of, is that for professionals? Is it for frontline professionals? Is it for volunteers? What's the structure that you need? Is it for commissioners? Is it, so it's being really clear again what that might be. I'm going to go on mute because there are going to be two dogs that are going to run out in a minute and chase the box.
I very much like what Paquita said earlier about professionalizing carers, in the sense of acknowledging the good job they're doing and this high level skills are involved and preparing them for different things. I would have thought COIN could do something in that direction just by alerting them, you're doing a good job, can be quite, I would have thought we could have a go there. Now, who else needs to speak? We've got another 7 minutes or so. Sanjay, Tony, Becky, Linda.
I pick up on Catherine's point about communities. There are a lot of mutual aid groups around which, so there's knowledge and experience there. And also, I'm really interested in the number of my friends who've got street WhatsApp groups. Sometimes they're dysfunctional and rather awful, but quite often they are very supportive. And so it's being done already. We just need to plug into something that's already there.
Yeah, I'd like to echo that. And I think during COVID, we were all helping each other, bringing food, buying paracetamol, and I have 2 refugees living in our home now, mother and daughter. And, I got to the network of my neighborhood, and they've all been helping. One of them's offering free English lessons. Another one was offering to take them out. So it's there. The goodwill is there. It's just harnessing it and using and by education, I actually meant educating the public. And I think films and popular TV programs and so on are actually a good way. We know that, for example, domestic violence. There was that was one. A way through these popular programs, but but you're right. Also, training volunteers. It doesn't take that much to create a volunteer network. It could be via community champions, of course, the profession also. But I was thinking more grassroots stuff.
Yeah. Looking for hands to hear. Could I just add a couple of things here? Is that there are an awful lot of carers around who could really, really do with being put in touch with each other and help to think through some practical things. Linda.
Yeah, I think there's some great ideas coming through, and in a sense, I suppose there's the volunteers are a brilliant idea, but the professionals have to know how to work with volunteers and be aware of them. And I suppose it's that network. I think you're right that there are WhatsApp groups, Tony, you're absolutely right, but they're not connected up with this particular issue. So who's going to orchestrate this? That's what I'm thinking. Yeah. It's about the orchestration of that so it actually gets in there. You're right, early years is wonderful. Everybody wants to get involved with the birth of the baby. You've got midwives, you've got the health visitors, there's a whole system around it. So I suppose in a way it's not quite the same at the other end, is it? There aren't these people with those particular titles that kind of work other than within the hospice environment, which is very well orchestrated. But if you're not within that system, you're not supported in the same way. So I love the fact that I think, Nikita, you mentioned the importance of education. That's where I'm coming from. I think that's very important. And one of the most powerful experiences I ever had, and this is somebody who's worked in higher education for a very long time, I sat in a school when funeral directors came in to talk about their jobs. And they were very young people. They didn't look at all how I expected funeral directors to look. I didn't expect them to look. I certainly don't think the students did either. And they were so enthusiastic. And the way they talked about how they worked with the family and how they communicated, and it was just extraordinary. And I think there's so much that we could learn if we could just communicate across the piece. And maybe there's something about, well, yeah, education and getting people aware of it. I mean, my own feeling is interprofessional learning is very important, but it has to be around the person. It's not going to be done in the classroom with multiple, professions there. It's got to be around the person and about their feelings, what's happening, the family, whichever it is. I think there's a lot more we could do within the education environment, from school, and this was a school, through to the first stages of professional education. There's some really good examples of things that have been done, but they've not been generalized. And that's my frustration.
Yeah. Maybe if we can talk about the general principles with some suggestions about how you and your might want to bring it about in your instance, that may help. Because frankly, you don't want everybody in your house. Quite a lot of people I don't want.
No, you want people to understand and be able to communicate on your behalf to others. You don't want a person that tells the story 10 times to 10 different professionals, for example.
Can I just say something, Paul? Linda mentioned hospices, and of course, they have such a vast fund of experience. And I mean, Dame Cicely Saunders has written a book about the whole process of dying and supporting people who are dying. But hospices don't just act as places where people can die. They can, as they did in the case of my father, put in end-of-life care in people's own homes. So I think it's really worth remembering that it's a very good idea to link in with the local hospice and just to make use of the resources and the knowledge and the expertise which they have and which they're often very, very willing to give.
So there's another thing COIN can do there, and linking up with work that people are doing here. The schools and the hospices and the funeral directors and the GPs and the local community groups and the street WhatsApp group could all be given opportunity to join in and find their own way of organically working in their neck of the woods. We've only got a minute left. Linda, so you wanted to say something?
I just think it is about empowering people. I really do. And what is it? Knowledge is power. I think there's an awful lot more that we could communicate and recognize the importance of that communication across the piece. So how do we do that is the next stage, I suppose.
I'm going to give Catherine the last word in a second, but just to add one thing I don't think has been mentioned is how powerful I found the dying of my wife to develop communities. I mean, I can't go out in the park now without one or two people tapping me on the shoulder. Really extraordinary. The Aussie Beaster, the rock band that sang at her memorial, now want to set up a charity in her name and put out an EP to put funds in so that they can adopt this sort of positive approach. This is 2 years after her death. I mean, this is extraordinary. Where did this come from, you know? So what does nice things look like? Well, something like that, when people just feel that they're part of an endeavor, it's nice. Any last hands before I give it to Catherine? Catherine, last word.
No, I think that last bit, Paul, is beautiful, to give people hope after they've lost someone and to make them feel that it's not in vain, they've not been completely alone, and that at least someone else cares, that through what they're going through and what, what their experience, and to be able to share that is probably one of the most important human connections, and to be able to verbalize that with other people is very powerful healing. So I think anything that we're able to do to kind of inspire more of that, particularly within our streets and communities, is definitely worth working towards. But no, I've really enjoyed the conversation, and thank you so much for inviting me.
Well, a small, many of us as want are going to stop by for 10 minutes or so just to debrief and think through the next step. But what we do know already is on Thursday, the 30th of June, Suleika Ali from the Community Services will be here to talk about the work that they are already planning to do in terms of changing the statutory services for end-of-life care. And I've been sat in on a couple of their meetings. I tell you what, there's nice stuff around the corner from their neck of the woods. Also from the CCG, they too are reforming end-of-life care in West London. Wouldn't it be nice if we could get both of them working with these kind of ideas, and that we can act as a little bit of a seeding of this sort of broader community, holistic, community citizenship. What's wrong with it? We get kids coming along to help out in end-of-life care situations who are thinking of going into medicine and nursing to see what is it like to deal with complexity and death and so on. That'll be the 30th of June. Laura?
That was just to draw attention to, is that the next date? So their next date is same time?
That's right.
Thursday,
the next date, the last Thursday in June. Now in July, it won't be the last Thursday. Basically, because there's a pop festival called WOMAD that can't be missed. But it will be a meeting, and not quite sure what that'll be, but it's going to continue this theme. A lot of people are listening on the edges of this conversation. There's 14 people in the room, but there's a lot more than that, sort of just listening to what we're saying.
Are you trying to take Fat Boy Slim's job, Paul? Just asking.
Sorry, whose job, Chris?
Fat Boy Slim, are you the new Fat Boy Slim? I mean,
I think actually RCGP might be. I'm invited to the National Gallery tomorrow night to see whatever they're doing, and they're keen to make music part of what people think about in end-of-life care. It's fantastic. You just allow the opportunity for people to talk, and by God, they talk. It's interesting.
Do you know about the Good Grief Festival?
No.
All right.
I'd like to, though.
Yeah, that happens every year or even twice a year, and there's a lot of talk about death and dying and so on. It's in a very positive, generally positive way. I'll send the link.
Thank you.
Because I did a bereavement session on bereavement with Julia Samuels, who you might have heard of.
Yep. Wonderful. There are loads and loads and loads of wonderful people in this territory.
2,000 people.
But there isn't an easy way to join it up. It's still seen as an individual pursuit most of the time. Really.
And then doulas. You mentioned death doulas, Catherine.
Oh, yes. We may well have July may well be on doulas, or September may be on doulas. Because this is the first time we've continued the theme this long, actually. Usually COIN moves from whatever theme is around that time, around integrated working, but this time this is stuck. Anybody else? Well, hopefully see you in June. In fact, you're all very welcome to just not sign off and carry on the debrief for the next 10 minutes. So it's all a very friendly thing. Laura, anything from you?
I just posted the link for the Good Grief Fest.
Oh yeah, I was just going to do that.
Yep, I put it up into the chat. Thanks everybody for participating in the chat and showing up. As Paul said, we have I know personally of people here in the US and in New Zealand who couldn't be here today, but wanted to be. This has been just such a fruitful conversation over the last few months, and very much so today. Thank you, Catherine, for all your time.
Nigel de Care Silva, who's chairing one of the primary care networks, is keen to be involved as well and get their primary care network to be involved. But of course, everyone's busy, with stuff.
Yeah, Catherine, thank you very much. That was wonderful. Thank you. Really stimulated a great discussion.
Pleasure. Thank you.
Okay. Yeah. Well, stay.